Working for over 16 years with patients with epilepsy, this topic of stigma is very dear to my heart, and we encounter it on a daily basis. So, kind of diving into it to prepare this presentation, I realize how much I don't know myself. So, just to kind of get everyone on the same page, the definition of stigma is a mark of disgrace of infamy associated with a particular circumstance, quality, or person. The synonyms can include shame, disgrace, dishonor, ignominy, or humiliation. Epilepsy stigma is the negative treatment and attitudes that people with epilepsy experience, and it can be the enacted stigma, which comes from the outside. So that's the unfair treatment at work, bullying at school, social discrimination, or denial of care. Or it could be a stigma that's felt by the patients with epilepsy associated with shame of having seizures or chronic disease, and the fear of enacted stigma. So patients with epilepsy worry about what others think about them. In the recent decades, more attention has been paid to life of people with epilepsy, and population-based study done in the United States found that 1/3 of responders identified the stigma, not the seizures, as the most difficult part of living with epilepsy. When you look in general at the epilepsy-related stigma, it stems from misunderstanding about the medical facts. So some people are not even aware what epilepsy really is, and they don't know that it's a well-defined medical condition with symptoms and specific treatments, and that if treated successfully, these patients can have successful lives. There are multiple misunderstandings and myths that give rise to the stigma, and it tends to be the highest for people with frequent seizures, but also people with just diagnosis of epilepsy can encounter stigma. Going back to history, when seizures were first described, we can go back as far as 2000 years BC, when the first description of seizure was found on Akkadian tablet from Mesopotamia. The description of a person with facial asymmetry, tense neck, eyes wide open and foaming at the mouth was found, and this condition was described as the hand of a sin. The Greeks called epilepsy a sacred disease and had more positive connotation to it, and associated epilepsy and seizures with genius and the divine powers. On the other hand, Romans believed that epilepsy was severely contagious and called the sufferers lunatics and moonstruck. In 700s to 200s BC, in Chinese literature, a description of first generalized seizure was found, and more common classification and categorization of epilepsy. For Chinese, the traditional treatment included herbs, massage, and acupuncture. Around the 5th century BC, Hippocrates and his scholars in Greece hypothesized that the brain might be the source of epilepsy. So we're kind of creeping up closer to our current understanding. Also, Hippocrates believed that epilepsy could be cured like other diseases, and he was the first one to introduce the concept of post-traumatic epilepsy. Aristotle in the 4th century BC speculated that epilepsy and sleep were due to similar mechanisms, and he described this process of evaporation resulting from the consuming food which subsequently caused a raise and fall in veins. And he hypothesized that this kind of changes affect consciousness related to epilepsy. When we come closer to our times in 17th century, Dr. Dusad in Sweden described seizures, epilepsy, and neurological disorders. William Cullen, a Scottish physician, outlined the facts that seizure could present in different parts of the body and could not always result in loss of consciousness. In 1800, Dr. Todd introduced the idea of brain function through electrical force and hypothesized that the electrical discharges lead to seizures. It was not till 80 years later where the human electroencephalogram was invented by Dr. Berger, and that proved that seizures were related to abnormal electrical activity in the brain. Subsequently, in 1935, Dr. Lennox demonstrated that there are also discharges preceding and following seizures, and the increase in frequency of discharges is related to convulsions. We cannot understand the severity of the stigma without understanding the statistics. So there are 65 million people worldwide affected with epilepsy, and 3.4 million of those live in the United States. There are 150,000 new cases of epilepsy in the United States each year. And 1/3 of people with epilepsy live with uncontrollable seizures because all the available treatments are not controlling their seizures. And about 25% of new onset epilepsies are diagnosed after the age of 65, with most common causes being cerebral vascular disease, head trauma, dementia, and neurodegenerative diseases. When we look at the pediatric population, epilepsy is the most common neurological disorder in childhood, with prevalence of 0.5 to 1% in children from birth to 16 years of age. Comorbidity of epilepsy and developmental disabilities as a dual diagnosis affects 15 to 30% of those children with epilepsy, and epilepsy in autism is seen in 20 to 30%. When we look at children with chronic illness, they have about 2.5 times higher risk of mental and behavioral problems. And since epilepsy is a brain disease, the risks are even higher. Literature quotes about 16 to 77%. And when you compare it to chronic disease like diabetes, it's only 11%. The cultural aspects of stigma in more modern world are diverse. In some Western cultures, views of epilepsy include more an approach as a medical condition, but the stigma exists is in misconception and safety of seizures, leading to discrimination in workplace and other situations. In Eastern cultures, epilepsy can still be seen through spiritual or religious aspects and viewed as spiritual possessions, leading to isolation. Families then seek alternative therapies, and which leads to delayed in diagnosis and treatment. In some African cultures, epilepsy can be viewed as associated with witchcraft or curses, and therefore opting for traditional healers and spiritual interventions instead of traditional medical treatment. In Middle Eastern cultures, stigma can be related to ability to marry and fulfill social roles like having children and supporting family, and in that way affecting family honor. The social consequences stem from interactions of patients with epilepsy with others and can lead to loss of self-esteem when they compare their quality of life to others, leading to isolation and withdrawal. Lifestyle restrictions when they stop doing things that bring them pleasure or satisfaction, and removing themselves from public life because of fear of seizure. There are also medication side effects that can affect their ability to interact with others and cause limitations in their activities. All of them directly affect their future ability to further their education, seek employment, subsequently affect their economic status, marriage status, and psychosocial well-being, and at the end also affect their overall health. When we look at mental health, epilepsy involves brain, so the prevalence of mental health problems is much higher in this diagnosis. We see more depression and anxiety, more learning problems, ADHD. There is also effect of living with epilepsy, with chronic worry about seizures, increasing anxiety, and feeling of shame or guilt or even embarrassment contributing to depression. And to that, we add the mood side effects of some of the seizure medications. Epilepsy can impact learning and cognitive function, so early diagnosis and educational intervention is really critical. Frequent seizures or seizures that involve specific areas of the brain can affect attention, memory, and processing speed, leading to difficulties in retaining information or acquiring information. Medication can also affect cognitive function and processing speed. Students can experience stigma from peers through bullying and can become more withdrawn and isolated. This affects their confidence and downstream motivation to learn and leads to withdrawal from school. There are many articles that look at stigma in epilepsy. A group of researchers from Case Western Reserve in Cleveland looked in correlation of stigma in people with correlates of stigma in people with epilepsy. They enrolled 120 individuals with epilepsy with mean age of about 42 years. 81 of them were men and 79 were African American. The factors that correlated with worse stigma were indicative of more severe or poorly controlled seizures, so more frequent seizures, and more anti-epileptic medications, worse seizure severity scores, mental health comorbidity with depression and other comorbidities, and factors related to individual functioning, perceived competency in managing their own health, like health literacy, health functioning, and self-efficacy, including quality of life. They concluded that stigma burden can be substantial among people living with epilepsy and may vary depending on contextual factors such as mental health comorbidity. Care approaches that screen for psychiatric comorbidities, address low health literacy, institute promising self-management programs, and employ effective health communication strategies about epilepsy misconception may reduce epilepsy-related burden. The International League Against Epilepsy Task Force also reviewed 332 publications and systematic review. All of these publications either address stigma or attitudes towards people with epilepsy. Negative attitudes towards people with epilepsy were described in 100% of these studies, and these attitudes originated in all groups, from general public to teachers to students, healthcare professionals, and also people living with epilepsy. Positive attitudes were linked with higher educational status in the younger age. The enacted stigma episode of discrimination against people with epilepsy was associated with poor epilepsy knowledge, less education, lower socioeconomic status, living in rural areas, and religious group identity. In people with epilepsy, felt stigma, on the other hand, was associated with anticipating or assuming negative view of others or self-stigmatization. And it was linked to younger age of epilepsy onset, poorer knowledge about epilepsy, and less education. The felt stigma was also associated with increased risk of psychological difficulties and impaired quality of life. We can now look into activities and local and international endeavors that help promote teaching and provide arena to learning about epilepsy. The newer endeavors are the International Epilepsy Day that is celebrated on the second Monday of February. This promotes awareness of epilepsy around the world. People from all areas can join individually or groups and focus their attention into spreading awareness of epilepsy. This gives opportunity to all stakeholders to join and speak about epilepsy in united voice and become more visible. This raises awareness of the disease at the international and governmental levels, and as well as the general public. This helps strengthen epilepsy movement by unifying epilepsy associations in the worldwide campaign, helps fundraising, and helps encourage discussions about epilepsy. International Epilepsy Day is a key initiative that was related to World Health Organization's 10-year intersectoral global action plan on epilepsy and other neurological disorders, or IGAP. This was founded in 2022, and it's a 10-year roadmap that contains specific strategic objectives to strengthen the public health approach to epilepsy and global targets of aiming on major treatment and inclusion gaps for people with epilepsy worldwide. They have two more immediate targets. And the first one, by 2031, countries will have increased service coverage for epilepsy by 50% from the coverage available in 2021. And 80% of countries will have developed or updated their legislation with a view of promoting and protecting the human rights of people with epilepsy by 2031. What can we do in our small world and more directly in our daily life? By dismissing misconceptions and myths about epilepsy, we can provide additional education to our patients, their families, and schools and society. We can teach seizure first aid to eliminate fear and panic related to seizures. We can address bullying at school and help students attain individualized education plans. We can create supportive environment, mentor, and share stories. there's so much that's being said on the media about other diseases, and autism is one of the more common ones. We have to be visible and provide mentorship to patients with epilepsy. We have to reach out to local organizations and support groups and gain sense of community for our patients. We have to work on coping skills and providing therapy to help them deal with their daily burden. And we have to support local, national, and international programs and initiatives to help eliminate the stigma.